Today I will discuss about ankylosing spondylitis. Ankylosing spondylitis is a type of seronegative spondyloarthropathy. Now, what does this seronegative means? They don't possess the antibodies that seropositive patients do. In most cases, the rheumatic arthritis patient tests positive for rheumatic factor and anti-citrullinated peptide antibodies. This indicates that the patient is seropositive. Now, when a patient tests negative for rheumatic factor and anti-CPP antibodies, yet they still display strong symptoms consistent with rheumatic arthritis, they are given a diagnosis of seronegative spondyloarthropathy. The most common type is ankylosing spondylitis. The first point we should remember about ankylosing spondylitis is male is to female ratio is 3:1. Generally diagnosed between 15 to 30 years old patient. 90% of patient is positive for HLA-B27 gene. It is an inflammatory condition affecting mainly the spine. It starts at sacroiliac joint. The earliest manifestation is sacroiliitis plus enthesitis, commonly the Achilles tendinitis. The key cytokine in ankylosing spondylitis is TNF-alpha. TNF-alpha erodes the annulus fibrosus of spine. For this, one disc glides over other, resulting in syndesmophyte formation. Syndesmophyte, that is bony growth inside the ligaments of spine, which predisposes to bony ankylosis, that is stiffness of spine, which appears in X-ray as bamboo spine. Most common complication is spinal fracture. TNF-alpha activates osteoclast, resulting in bone resorption, which causes fracture. Now, how does a patient present to you with ankylosing spondylitis? Young adult male with lower back pain and stiffness, pain in buttock region, pain increases on rest and at night and in early morning. It takes at least 30 minutes to improve the stiffness in the morning and reduces with activity. Peripheral joints are also involved in ankylosing spondylitis, like shoulder joint, hip joint, dactylitis may also occur, involving the whole finger. It can also affect other systems of our body, most commonly acute anterior uveitis. The cardiac manifestations are acute aortic regurgitation and heart block, interstitial lung disease involving mainly the upper lobe. Most common interstitial lung disease is non-specific interstitial pneumonia. Kidneys may also get affected, like secondary IgA nephropathy. In the skin, it may cause psoriatic lesion. It can also cause inflammatory bowel disease. Now comes the investigation. There is a test known as Schober's test to assess how much mobility is present, particularly in lumbar spine. So we ask the patient to stand straight. We identify the L5 vertebra on patient. Then we mark a point 10 cm above and 5 cm below the L5 vertebra. So the distance between these 2 points is 15 cm. Now we ask the patient to bend forward as far as the patient can. Now we measure the distance between these 2 points. If it is less than 20 centimeter, then it indicates restriction in lumbar vertebra is present, which supports the diagnosis of ankylosing spondylitis. Now the radiological evidences. Earliest radiological sign is blurring of cortical margin of subcortical bones, sacroiliitis, bony erosion, dagger sign. Dagger sign is a single central radiodense line in X-ray plate related to ossification of supraspinous and interspinous ligament. Now the trolley track sign, radiograph of lumbar spine with linear vertical increased density along the spinous process. This single central radiodense line along with the two more lateral vertical lines are known as trolley track sign. Now the Romanes sign, edges of vertebral bodies appear as shiny corners in X-ray plate, also known as shiny corner sign. Now comes the management. The mainstay of treatment is physiotherapy. The first line management is with non-steroidal anti-inflammatory drugs. Intra-articular steroids relieve pain. Sulfasalazine for peripheral arthritis. The drug of choice is TNF alpha blocker.